Dr. Ahmed Issac, if you may introduce Dr. Bandar, please.
Thank you. So the next speaker will be Dr. Bandar Alshehri, who is congenital and also in structural interventional cardiologist at Prince Sultan Cardiac Center, Riyadh. His talk will be about valve for a failed bioprosthetic valve, surgical valve.
السلام عليكم يعطيكم العافية مساء الخير. I will speak about the bioprosthetic valve failure management strategy in mitral position. I have nothing to declare. So I will start my talk with a presentation about one of the cases which was done recently in our center. Our patient, 66 years old male, his known case of diabetes, hypertensive, dyslipidemia, ischemic heart disease status post-CABG, mitral valve repair using Edward Physio 28 millimeter on 2013 on other hospital, presented with a history of significant dyspnea NIHA class 3 for the last 6 months. So in the echo, the ejection fraction is 45%. The mitral shows surgical repair and surgical annuloplasty, and there is severe residual regurgitation with a single jet directly centrally. The mean diastolic gradient is 6 millimeter mercury. The cath showed patent graft with multiple vessel disease in the native vessel. So as you see here, this is the TEE, which showed the significant regurgitation, central, and the heart team discussion.
So we have now, I will summarize the case, someone in his late 60 or 70, CABG, patent grafts, and we have a Physio 28 mitral valve ring, symptomatic severe MR, and we saw the images just a while ago. So this is like our business as usual. Every day we have something like that. So I'm going to start with my right. I mean, what do you think is the best option for this patient? Should he go for a redo surgery, or is there a percutaneous option, or just walk away?
Well, thank you very much. I believe the history of this patient speaks without precluding or without, discussing their heart team a decision. I think if you have a bypass surgery or prior bypass surgery, a second open heart surgery or a minimal heart surgery is always a risk. So my vote in this particular case would be to going percutaneously. And try to avoid risking anything happening to the graft.
Dr. Makhdoom, what do you think? I mean, you're the surgeon. We're going to present this to you. What is your most concern in the redo surgery in these particular cases?
Obviously, the grafts.
The grafts.
The grafts.
So we're going to be in your way, and it's going to be an issue.
She had an RCA and.
RCA and also the OM and the Lima 2 LED.
Yeah. So there's one option for redo surgery for mitral intervention with the patient who had previous sternotomy is to go through the right chest through a mini thoracotomy approach. But also in this patient, if the right graft is crossing the right atrium, is going to be an issue. So a CT scan will help to see where the graft exactly is, because some surgeon will lie the right coronary graft on top of the heart rather than the right side on the atrium.
Okay.
But I have a comment, please, if you don't mind. In this case, I assume this was an ischemic MR.
What's it?
All the grafts are patent.
I assume the previous pathology was an ischemic MR.
I'm not sure about it. The
assumption.
I assume. Because the treatment for the old treatment for ischemic MR is the ring annuloplasty. And first of all, the physio ring is not a ring that we use for ischemic pathology. Second of all, the latest trial that for ischemic MR proved that repair for severe ischemic MR does not work. Mm-hmm. No matter what you do, and the repair, it always comes back. So replacement is the choice and the trial only came out, I think, in 2018 or 17, if I can remember. So nowadays, if a patient comes with ischemic mitral regurg who's going for CABG, if it's severe, it has to be replaced.
So we talked about CT and heart discussion. So the leniency around us is like going for percutaneous option rather than surgery for the risk that mentioned.
Yeah.
So what have you
So
done
actually,
next?
this is our decision and the heart team discussion to give the patient the choice to go proceed with transcatheter valve implantation. So maybe Dr. Merdad, you have something to teach us about the rings and the type of rings?
Can we have the smart screen, please?
Mic, please. Okay. So when it comes to valve and ring, there's a few things to consider, or 4 things to consider for a safe performance of the procedure. The first thing is the ring itself. We have different types of ring. We have semi-rigid ring, like the Physio 2 ring shown here in the top left image. The nice thing about this ring is that it gives you a good combination between anchoring and circularity, so that if you inflate a valve in that semi-rigid ring, it can actually circularize and you can fully expand your prosthesis. The second type is a sort of a band where you have an incomplete ring. Oftentimes this is flexible. Unfortunately, this gives you, poor anchoring. So even though it can circularize, the anchoring of the valve becomes an issue, and this is important in the mitral position because you're dealing with high pressure chambers. And so oftentimes this is actually considered not a favorable kind of ring for this procedure. The third type is a rigid ring. It's a complete rigid ring, and the problem with this kind of ring is that it interferes with full expansion of your transcatheter prosthesis, and also because it does that, it doesn't circularize. So oftentimes you have PVLs that are on the sides of that, rigid ring. So also considered somewhat less favorable, depending on the type of the rigid ring, but mostly less favorable for this kind of procedure. The second thing to consider is actually the valve and the delivery system. Oftentimes we use prostheses with short profiles, often balloon expandable TAVI valve, the Sapien system. We probably have the most experience with that. And the nice thing is that, again, it has low profile so that it does not result, or have less probability that it would result in LVOT obstruction. And because it's balloon expansible, you can sort of control the expansion of the valve and oversize if needed. The third thing is the risk of LVOT obstruction. So this is often stratified by screening CT. We look for the size of the neo-LVOT, and oftentimes a size that is less than 170 to 190 millimeters squared is considered high risk for hemodynamically significant neo-LVOT obstruction post-deployment. And then the risk of embolization, I mentioned the high pressure system. Oftentimes if you use a ring that is 32 millimeters or more, the situation becomes less favorable because it's too large for the available valves, and then you end up having to oversize. If you oversize, you run into a risk of LVOT obstruction, so you need to think about that balance. So often we do it with patients with rings that are less than 32 millimeters in size.
Yeah.
Great.
Okay.
Yeah.
So if you look, so actually we did a cardiac
back to
CT,
the
which
slides.
is, as we know, it is mandatory in each case to proceed with valve and valve, or also valve and ring. So as you see, it is a complete ring. And also, if you look to the area was measuring around 370. The new LVOT using Sapien 23 was 404. And also the diameter was 24.6 by 18.3. So usually in these type of cases, we like to take like a second opinion from the company or or any proctor who is doing a good number of cases. So actually the suggestion by the company is to proceed with 23 valve inside the ring, considering this annulus area and the new LVOT. But actually, when we went and looked for the valve and ring or valve in valve application, it gave us that the original area, it was around 401, and also the CT area is almost around 400. So the recommendation by the app is to proceed with 26 valve instead of 23. So we did again our measurement using the new valve, which is 26, and our LVOT is very large actually. It can accommodate the 26 valve. It was more than 300. So I want also to hear from the panelists, what do you think? Will you go with 23, which is the recommendation by the company, and already there is some case reported exactly with the same ring, or you will go with the 26?
Dr. Goufi?
Great case, Bandar. I think the concern about oversizing is the pinwheeling in this situation. And you end up with a less pinwheeling of the valve, with less expanded valve and a higher gradient. If the area is accurately measured by the CT scan to be 400, I would have chosen a 23 millimeter valve.
Okay.
Yeah, I think I would vote for 26 here. And thinking about the follow-up situation with ring surgery, I wonder if we should not recommend to the surgeon to use semi-rigid rings rather than rigid rings, because with rigid rings, you can't really do anything. We know it is hard in an asymmetric ring to put a symmetric valve in. You have to deal with PVL. So I would vote here if that's
So
the
we
question.
have 226. Just قول لي الرقم. Dr. Makhdoom, 26 or 23? None of the above. Dr. Ahmed?
Just a comment about the CT. So the ring is at the level of the mitral annulus, which is slightly away from the LVOT. But I think it is better to put a virtual valve and see the distal portion of the valve, and then you make the new LVOT. To tell you the truth, in the ring, like valve and ring, LVOT, like new LVOT is not a great problem, probably because it is just one valve, it's not two valves, which is like valve and
What
valve.
about you, Zakaria? You're the expert.
So actually,
Go
yeah.
with the 26, yeah.
26. Okay.
So 26.
When I choose the 23, I found that the oversize, it will be around 3%.
Okay.
Regarding, which is, I don't feel I will be very comfortable to implant the valve and ring with this oversizing. So actually, we decide as a team to proceed with 26, considering this large LVOT.
Can we have the slides up? Yep.
So I think, as you see here, can you see the slide? Okay.
Yeah.
So as you see here, that now we are doing the transeptal.
Any
So-
particular steps for the transeptal by, you want Anas to take?
Okay, go ahead, Anas. You can explain it.
Mic for Anas, please.
Can you turn on
Yes,
the
we
mic?
can hear
Okay,
you.
so for the transeptal, you want to puncture just above the mitral valve. So oftentimes, so this is the RA on the left side of the screen, and this is the fossa ovalis. This is the superior vena cava, inferior vena cava, and this is your aortic valve. So this is superior inferior plane, and this is your AP plane. And you want to puncture a little bit inferior, a little bit posterior, right around here, to puncture close to the just above the level of the mitral valve. What I want to deliver here, if we go to the next slide, yeah. What I want to say here is that what you need to remember is that superior does not mean higher above the mitral valve. Okay, so if you look at this is a 3D printed model. You can look at the mitral valve down here at the bottom. This is superior, this is inferior. This is the actual direction of the IVC, so that if you puncture too high superiorly, you're not going to gain height. You're actually just going to puncture too anterior, and you're going to come very aorta hugging, which is not something you want to do for this kind of procedure. So you want to puncture a little bit inferior and posterior right above here, so that you end up right above the mitral valve.
Yeah. So I think this is very important tricks, because really you have to spend time to choose the most appropriate position to puncture,
Slides,
because this
please.
will make your life easy. And also you can correlate during the fluoroscopy. Please share the slide, because
Yeah.
with the
Zakaria,
panelist,
you're like
the panelist.
been with
The audience, they can
the
see.
partner
Okay.
of crime with
So
Bandar.
as you see here, you can go a little bit REO and try to know exactly what is your orientation to the valve. And after that, we use the Agilis catheter to go directly and help you to cross the valve. The Agilis catheter, it is important for two things. Number one, it will direct you to the valve exactly, and it will and you will cross easily. Number two, also, it will help you to push your stiff wire, the safari wire. Because if you think that it is very, very easy to cross with the GR, yes, it is very easy to cross with 3-5 wire. But once you will introduce your safari wire, everything will go back. Then you will start from the beginning. So really, I like to, in the valve, all the cases, we are using, number one, the Agilis catheter, and also the dry seal. The dry seal, and for sure the Baylis, because you can have the most accurate transeptal puncture. The idea from the dry seal sheath, you can go ahead with the regular Sapien sheath or Edward sheath. But the issue, sometimes if you have difficulty to cross, then you need to take everything out during the procedure. And this will compromise the valve. But actually, with the dry seal, you can go in and out, dilate more, try to change the anatomy. It's very easy to retrieve your valve if it did not work. And as you see here, sometimes you can cross with the pigtail directly, and then you can use the Safari wire. And for sure, you need to dilate the septum very well. You can use 20 millimeter balloon or sometimes 14. Most of the time, 20 will do the job, but take your time with the balloon dilation. Do it multiple times. Sometime, give it a time to dilate very well. And also, don't wait a lot after dilating from bringing your valve because there is a recoil. It will come back. So after that, you will try to choose the most appropriate angle fluoroscopically to orient your valve with the ring. And as you see here also the 3D, it will give you a help and to know exactly where are you.
In a minute, Bandar, could I like hear from, go back to the previous slide, hear from a thought from Dr. Zakaria with the NPR. It's been growing much of popularity with the intervention when it comes to the left side. So what are your thoughts about it?
So definitely it will help you to look at the valve from different direction, anterior, posterior, medial, lateral, and also inverse view for the 3D. And it will help you positioning, direction, and also during the ballooning and continuously. Maybe we are not able to capture everything, but also we will observe if it moves or not. And you are at the same time observing the LVOT and the LVOT view or any
Obstruction.
Bandar,
what about the flexor sheet? How much of introduction, because you said
Yeah.
slow control. What is your thoughts?
So actually it is very important during taking out the pusher. Number one, you have to be away from the balloon. In the same time, you have to be still inside the LA, because if you pull the pusher very far, most likely you will go to the RA. So if you want to push in, it will have difficulty to deliver the valve. Number two, you have to fix your wire very well and try to inflate very slowly. Usually we don't pace during deployment the valve because it is you can control it actually, and you by slow inflation and try to adjust it every time. And you have to know that the valve will shorten from the LA side, and try to take your time during the deployment. It is not like a TAVI valve. You have to take your time during the deployment and try to coordinate between the wire and also the pushing force to be centered all the time. So as you see here, the valve is well positioned, and after that we remove the Safari wire using the big tail. Then you can measure the pressure easily, and it will be, inshallah, it will be most of the time straightforward. So as you see here, that the gradient is around 5, and also there is no any regurgitation.
And no LVOT obstruction.
Yes. And actually post-op echo showed that the gradient was 6 millimeter mercury at 70 beat per minute with no leak.
Dr. Gofi, Bandar talked about different sizes, and he talked about the oversizing. Would some of them talk about flaring or adding more CC? What is your take in this particular case? Will you go for more or less?
I think nobody argued with the success, but I will still go with the 23 and oversize it. The flaring did it very well towards the LV side. More important when you are doing it with a valve and valve. The question here, in fact, just the deployment, which is very tricky, great result for a ring case, because with the valve and valve, you do have more fluoroscopic landmark. Your strategy was 20/80?
Yeah, go back, Evan. Yes.
What was your strategy when you are deploying in the ring? Like 20%?
Yeah, 20% from the LA side and 80 in the LV side.
Yeah, so this is, again, this is something that actually very important to have a discussion between you and the other operator. If you don't have echo, echo sometimes very helpful, but also in this case, you have a very real.
Sometimes.
No, all the time is helpful. But I'm talking about clear fluoroscopic landmark. I would have focused mainly in achieving the 20/80.
There has to be a communication.
Yeah, actually, it is
to be
very
on the same
important, the
page.
20/80 concept, because the skirt, actually, it is in the atrial side. So if we make it 50/50, maybe you will have significant paravalvular leak.
Yeah.
So you have to be very sure. And the difference between, as Dr. Gofi, he commented about the 23, the issue that the ring is different than the valve. The valve, it will not expand or it will not shrink. While the ring, I believe that with the time, since 2013, sometime it will be like downside. So I feel maybe it is safer to put it like 26 without no need to flare it more or to increase the volume.
What about your thoughts? Any thoughts about this now? Successful case, next day, everyone happy. The gradient is 6 at a heart rate of 70. Any thoughts about the post-op medication, discharge, anticoagulation?
Well, you can't beat happiness. I mean, if you're successful, obviously, then, you know, it's hard to argue. I would still argue the non-pacing issue because, well, first of all, we're doing with pacing because it's a two-man approach, and if the two do really not coordinate well, then the valve will slip, and then you have a problem. So while I understand, you know, it's personal experience, but I would still go for 20/80, and I would prefer pacing depending on the team's experience.
What about Anas? I mean, you have some experience with these kind of cases. Any any home message from an structural imaging point of view? Like what you're going to tell me during the case?
Yeah, so just for this particular case, planning is paramount. You really have to plan. As you said earlier, it's 90% planning and 10% execution. Overall, there's no, for the whole session, there's no one size that fits all. You always have to choose the right intervention for the patient, and planning is paramount. And if I may just add one point regarding TMVRs in general, is that also with TMVR, especially with TMVR, there's no one size that fits all. If a patient that fails screen a valve, they may pass screening in another valve. If they fail screening in all valves, think about septal modification. There's always more steps that you can do for your patient. Yeah.
Okay.
Yeah.
You want to go have
Okay.
next time? Okay. Thank you, Bandar.
Thank you.
So we have like 3 minutes to spare. I would like to hear from Dr. Makhdoom. I mean, it was an amazing demonstration, making it simple, though it's very complex. But if things went wrong, and I called you, so what are you going to do at that time? I mean, is there any particular approach or something you would have asked from me if things went down, just keep this in place, or anything in particular?
It depends. It depends. When did you call me?
But I pushed it in the LV.
No, it depends if, I think everything has to be planned
Okay.
and discussed from the beginning. And all the scenarios been calculated.
Yes.
We're always there for the patient. And I'm, personally, I believe if the patient is not too high risk, I mean, the procedure is high risk, but the patient is viable, we should go all the way. Yeah.
I think I'm asking that because there has been some case reporting about having the basket or NU, and they're now snaring the valve from the LV and taking it all the way through the septum. So kind of like a cowboy move, but it might happen. So that's what I was asking. But you're there to help.
Yeah,
The final comment from Dr. Ahmed and Dr. Zakaria.
Yeah, I think the key of success here is patient selection, planning, careful planning. You have to calculate every move and put no chance of mistakes. Or chance of chance. I mean.
I just want to see the great success for a structural program is great imager.
Yes, that's true. That's true. Dr. Ahmed, speaking about great imagers.
No, actually, yeah, you made our life much difficult. Now
Thank
you
you.
ask
That's our
for
job.
more and more and more information, but we are learning.
Thank you.
Okay, so yeah, planning is extremely important, but also to sit together
And communicate.
communicate and find out what do you want from us and how do we make your journey in the cath lab easy. Yeah.
Thank you, Dr. Ahmed. With that, we conclude our session. Thank you, everyone. Thank you for all the panelists to be part of this. I appreciate your help. Thank you, everyone. Thank you. Thank you.